we'll just go straight into mine then. So today we're just going to talk about some ketamine for pain treatment and go with a little bit of the history and then talk about more of the clinical side of things. I have no disclosures. Goals will be to kind of understand the pharmacologic principles of ketamine, learn the mechanisms of actions, identify the indications of use, and identify the
Sorry,
relative.
Barnhart. May I interrupt you? Because
Yes.
your full screen is not showing.
Oh, the screen's not showing? Oh
The full
my.
screen is not showing, only the toolbars.
Oh, I'm, it's giving me, I'm not sure. Let me try it again. Okay, is that better?
Yes, it's good now.
Okay, great. Um, so as far as the objectives, we'll identify the indications for use, talk about some relative contraindications and side effects, and try to identify patients who would benefit from ketamine. And we'll try to talk about the critical care side of things. So ketamine was first discovered in the 1950s. It was actually synthesized in Michigan, but before it was developed, a compound called phencyclidine or PCP was synthesized in 1956. And in this, the study showed that at low doses, it caused kind of like this drunkenness, stupor in rodents and in monkeys. However, as they started doing more and more increasive doses, they showed that it produced anesthesia. So it was shown to be safe in humans. However, it was limited by very startling side effects, and it was a prolonged emergence delirium and hallucination that occurred with PCP. So they kept the same molecule and they started modifying it. And that's when they came up with ketamine in 1962. It was shown to be shorter acting and to have less delirium and side effects. So in 1964, Dr. Grunter Corson in Michigan first gave it to a human. And then by 1970, it was approved for use as a general anesthetic under the brand name of Ketalar. So how does ketamine work? Essentially, we have excitatory glutaminergic receptors in our brain that the ketamine will block at the NMDA receptor of the glutaminergic neurons. Um, so that will kind of calm down any type of action potentials out of the central nervous system. So ketamine consists of a racemic mixture of S enantiomers and R enantiomers, and it has a poor oral bioavailability. Only about 20-ish% will be absorbed if you give a PO dose of it. So in general, we give it through the intravenous method. The half-life is approximately 2 hours. So it does have a pretty short overall action. It's rapidly metabolized by the hepatic microsomal cytochrome P450s, specifically the CYP3A4 and the CYP2B6. And it's metabolized to norketamine, hydroxynorketamine, and dehydroxynorketamine. Some of these metabolites do have a little bit of action at the NMDA receptor also. And predominantly, ketamine is renally cleared 90%. So when you give ketamine, there's several things that you can see, and it's more of a dose response. So the larger amount you give, the more effects you'll have. So at high doses, you can get increased heart rate, blood pressure, and this is caused by sympathetic stimulation that is caused by the ketamine itself. Also, at higher doses, you can get myocardial depression, especially if the catecholamines are depleted in someone who's been under a prolonged stress state. So again, especially for ICU patients, I would think about having a possible increased myocardial depression at high doses, especially if they've been in a stressed or septic state for a while. You can also get increased salivary and tracheal bronchial secretions and bronchodilation, which is a kind of a unique thing about ketamine. So for refractory asthma, you can use ketamine to help with this bronchodilation. Also, a side effect that even occurs at lower doses, especially even analgesic pain doses, is nystagmus. Patients will often complain about kind of seeing two, double, or having other blurry vision. So as far as side effects and adverse effects of ketamine, um, they can get hallucination. Again, it's more dose response. Higher doses, you'll get more of a hallucination possibility. You can get depersonalization. Some people have panic attacks. I do talk to people before giving them ketamine about these possibilities. And if they are bothered by it at all during the treatment, that we can turn it off and it will go away pretty rapidly. And they usually seem pretty understanding, especially if they're in a lot of pain. Um, you can also, patients can describe feeling high. At higher doses, you can get nausea and vomiting and hypertension. Interestingly, long-term repeated high doses can cause hemorrhagic cystitis and liver toxicity. Um, so as a little disclaimer, it's much more of an issue, I think, here in the United States is that any drug that alters the sensorium can be a drug of abuse. So people can divert it and use it illicitly to get high. So some relative contraindications. So anyone with extremely severe cardiovascular disease or poorly controlled hypertension, pregnancy, elevated intracranial pressure or ocular pressure, severe liver disease or active psychosis, I would be cautious with. Um, I've used it in patients with severe cardiac disease, again, at low doses for pain, and they tolerate it well. So everything you have to take in context of your patient. Precautions, I would be careful with someone with a pheochromocytoma or other histories of psychiatric illness or active substance abuse. So those are just relative, use your best judgment. I've done it in the contraindications and they've done fine. It's just listen to your patient. So clinical uses, general anesthesia is how it was originally developed. However, it has much more attention now for pain relief and analgesia, especially in the perioperative period. Also, recently in the United States, they've been using it for antidepressant effects, especially a nasal form of the S-ketamine enantiomer, for treatment-resistant depression, for people who won't or haven't tried electroshock therapy or have and they still have depression, they can often use ketamine to help with their symptoms. And as I mentioned earlier, it can be used for asthma as well as refractory seizures. So for pain, ketamine will enhance the descending inhibitory pain pathway signals at the level of the spinal cord. So we all have our natural ways of kind of tamping down pain that is mediated by the central cortex. And ketamine will enhance these inhibitory pathways, as you can see in this diagram. So it enhances our natural ability to stop pain. It also helps prevent central sensitization in the dorsal horn neurons in the spinal cord, which is very important for the development of chronic pain. So essentially, when you get central sensitization, you are much more reactive to any type of input or injury, causing much more of a perceived severe pain position. So when we use ketamine, we're trying to reduce this modulation into becoming more of a chronic pain phenomenon. Ketamine also enhances the endogenous response to opiates and decreases the opiate need for acute pain. So this helps give opiate-sparing analgesia. And why is that important? Opiates have a lot of side effects: constipation, immunosuppression, respiratory depression, especially if any type of patient has some type of lung issue. So we can use ketamine and not use opiates to help with this acute pain, and it's much safer. Um, I also like to use ketamine for people who are on chronic opiate use already, because it allows us to use lower doses of opiates to help treat their pain. And similarly, we have an opiate epidemic in the United States where people are abusing opiate drugs and fentanyl. So anyone who has a history of this abuse, we like to use ketamine again to help with their pain. It works better and to help reduce the amount of opiates. And the opiates or I should say, the ketamine may reduce the opiate-induced hyperalgesia. So people who are on opiates for a long time period, sometimes when you give them more opiates, the pain is actually worse. So ketamine can help reset these receptors to make the opiates more effective. And even after we stop the ketamine infusions for our patients, the effects of pain relief have been shown to kind of be continuous even after we stop. So it helps the patient's pain while we're doing it and even after we stop. And the mechanism is still not really clear of how that works but it's seen clinically. So further benefits, it helps with neuropathic pain. So when you think of neuropathic pain, it's that burning, searing, tingly, lightning strike feelings. And ketamine is very good at treating this type of pain. Opiates, not so much. They kind of just dull things and make people feel better because they're overall dulled. But to actually kind of treat the neuropathic pain, ketamine is very useful. So anyone who's had a limb amputation, and then they have the feelings of the limb still being there and pain in the limb that does not exist, ketamine will help with the phantom limb pain. Um, Also, any type of ischemic pain. So if there's been vascular compromise, either chronically or acutely, ischemic pain is a neuropathic pain that's mediated from ischemic neurons. So the ischemic pain, it responds well to ketamine also. So you may also have other pain, chronic pain syndromes that are hard to treat, uh, such as migraines, fibromyalgia, or CRPS. And ketamine really helps with treating these hard to treat pains that are more of a chronic nature. And that usually requires prolonged, like couple hour infusions of ketamine to help with that. Um, Benefits, again, as I mentioned, it's used for depression. So you can get a secondary positive effect on mood in a patient when you give them ketamine. And kind of the take home for the overall benefit is it does not suppress the respiratory drive. So it's safe. You can get analgesia. You don't have to worry about them going into respiratory arrest. Limitations, and this is kind of more from the United States regulations. It's classified as a general anesthetic requiring anesthesia to give it, at least in the United States. Um, IV infusions are the best way to give ketamine, and you need to have special equipment or protocols to give that infusion. Um, Side effects can occur with the patient, so I do set expectations with them and the staff, that they may have unpleasant hallucinations or dissociations. However, at doses for pain, they most will tolerate it. Also, I tell them it's reversible. And I also say that when you really are in pain and you need ketamine, you really don't have the side effects. If, say, the patient's getting it and they start having side effects later on into treatment, they usually don't need ketamine at that point. They've kind of had their treatment uh, round. Also, because there is the potential for hepatotoxicity, over time. Monitoring LFTs can be important, just to make sure that they aren't bumping, but it is very rare. So as a vignette, a 50-year-old gentleman with low back pain on some oxycodone or an opiate 4 times a day to help with his pain. He underwent a large belly surgery, XLAP, for a small bowel section, and now he has nothing by mouth with a nasal gastric tube, and he's unable to take anything by mouth to help with pain. He says it's 10 out of 10, very severe and unable to move, and he's getting some IV opiate intravenously which isn't helping. His renal functions and liver functions are within normal limits. So dosing for analgesic ketamine starts between zero point 0.1 milligrams per kilogram per hour up to 0.15 or 0.2 milligrams per kilogram per hour. And these are very low, safe doses. Discuss the possible side effects and review your function parameters. So for this patient, I would give them ketamine and multimodal analgesia. So using a lot of different pain relievers together at lower doses to reduce side effects and improve their functionality. So I would do Tylenol and possibly a patient-controlled pump where they can press a button to get the opiates. So after the ketamine infusion, the patient's pain went down to a 4 out of 10, and they were starting to be able to be more functional and walk and rest appropriately. So as far as kind of more in-depth guidelines, there is a acute pain guideline produced by the Acute Pain Society for using it in the perioperative period. So there's that one. But then there's also a chronic pain guideline for more chronic pains like CRPS or migraines that is released from the chronic pain societies. So those are the guidelines there that provide a lot of detail. I thank you. What questions do you have for me? Always feel free to email me also. I'm more than happy to give whatever help.
Okay. Right, here we go. Okay, so my talk is specifically on the role of regional anesthesia for thoracic and truncal trauma, but I realize that some in the audience may have received the lecture from my other colleagues previously, kind of with an introduction, and then some of the that are newer to the group may have not. So I purposely have included some introductory slides as well to sort of set the stage for why we're talking about regional anesthesia and its role within multimodal pain management. I have no disclosures, except that the more I teach, the less I make. No, I'm joking, but no financial disclosures. And so as introduction, I want to make sure that we have a context for understanding the prevalence and consequences of undertreated pain in the ICU. And then I'm going to also touch on 4 main obstacles to assessing and treating pain in the critical care patient. Now, I understand from prior email exchange that there are certainly many traumas that come in that you see clinically. Some of these are gunshot wounds and stab wounds, so I think truncal trauma is hopefully very relevant to your clinical practice. Our learning objectives are to simulate receiving a consult. If you were the friendly regional anesthesiologist, what information would you want to know from your critical care colleagues? The indications and limitations of performing regional anesthesia for chest wall injury specifically. And then I'm going to lightly go over the anatomical structures of chest wall blocks. And again, I'm happy to be available at the end of this lecture and by email if you have further specific questions, but I'll keep it fairly general for the purposes of our broad audience. So we see this common scenario, unfortunately, rather frequently. And we know that patients present initially with baseline stable medical conditions. There is some event where they have an accident or they have a surgery, that changes that baseline medical condition. They end up in the critical care unit. And even when they leave, they may still have a very long haul in front of them of recovery and potential disability. So we expect, given certainly their injury, that there is going to be some pain, but there's a subplot over a period of time, both pre, intra, post-procedural in the ICU and beyond, where pain is a subplot of their acute critical illness. And so this diagram is just showing sort of that interplay between perioperative pain, ICU procedural pain, and post-traumatic pain. And we see, it's been published in many articles. Severe pain and moderate to severe pain is frequent in this patient population. So we're familiar with this idea of a multimodal approach. And there are a variety of options. So my colleague, Dr. Barnhart, he mentioned ketamine specifically. There are certainly the non-steroidal anti-inflammatories, muscle relaxants, opioids, local anesthetic infusions, gabapentinoids, such as pregabalin or gabapentin itself, education, communication, settings, expectations, realistic expectations with patients and their providers or family members. And then in the red box, of course, is my love, and that is intervention. So nerve blocks, epidurals, neurolysis, trigger point injections, spinal cord stimulators. I personally do not place, but those are within the larger arsenal within our toolbox. And those would be probably placed after long consultation when other avenues have been exhausted by a chronic pain physician. We know that there are consequences to uncontrolled pain, both in the short term on the left and in the long term on the right. So uncontrolled pain can certainly contribute to prolonged ICU stay. And the long-term consequences of uncontrolled pain are very serious. They are this increased risk of chronic pain, decreased function and quality of life. So I know when I go to see patients and assess their pain, I can look certainly at their vitals, behaviorally, but ultimately I want to know how their function is. Are they ambulating yet? Are they breathing well? Are they going to be able to live at least some semblance of their prior life? Maintenance of function is very important, and the role of regional to attain that. There's increased risk of post-traumatic stress disorder up to 25%. And there are certainly obstacles to achieving adequate analgesia in the ICU. So one of the first ones is this inability to communicate, right? Sedation, if the patient is intubated, if they're delirious, and we need reliable pain assessments. Multi-organ involvement, which I've highlighted in gray. And here we are. Right, so we know that just absorption itself of these multimodal agents can be altered for this population. They may accumulate metabolites, especially if renal or hepatic function is impaired. And there are limitations in your procedural access, safety, and options, even for the blocks I place. So if a patient has a nerve injury, for example, in the extremity, I could do a block, but it may not be appropriate. The risk profile basically supersedes the benefit for that specific patient. We talked about opioid use in the ICU and obstacles to adequate analgesia. Certainly, there are psychological stress issues that need to be addressed before we do or concurrently while we're providing procedures. So as part of my own education, I went to Society of Critical Care Medicine, and I was curious what guidelines they actually had for regional nerve blocks, right? That's supposed to be the focus of this discussion. And I was a little bit disappointed. I still think it's worth reviewing, especially for those of you who are in training. These PADIS guidelines from 2018, I believe. So PADIS, P for prevention and management of pain, A referring to anxiety, agitation, sedation, the D for delirium, again, those psychological issues, I for immobility, you have patients who were once very mobile, now they are almost bedbound, and S for sleep disruption. And I like this framework for organizing my thoughts when I approach a patient. So these guidelines, the most recent guidelines for PADIS, actually you'll notice under P, it says no update, see prior guidelines. So to save yourself time, you just go to the first generation of guidelines. I was a bit disappointed because when I searched that document, you see there's only one search finding for regional anesthesia. And so I hope that this lecture provides or enhances what we know that's in the literature, but is not probably so obvious in these SCCM guidelines. I think there is a need. So let's simulate receiving a consult as your friendly regional anesthesiologist. We're going to talk about indications and limitations of chest wall blocks, and then briefly touch on anatomical structures. So a case, let's say we have a 35-year-old man. He is an unrestrained driver with an unknown medical history. He's brought to the operating room after a motor vehicle collision with a degloving injury of the left hemothorax. He has avulsion of the breast tissue and pec muscles. During pre-hospital transfer, he received 4 units of fresh whole blood, and in the OR, he's gotten multiple units as well. Continuing our case, the patient's extubated in the ICU upon arrival. From the operating room, on exam, he's clearly in distress due to his uncontrolled pain. And on exam, his heart rate, he's clearly tachycardic. His blood pressure is slightly elevated, but he is satting poorly, and his respiratory rate is high. He's requiring high flow nasal cannula. All right. When you go to examine him, you realize under all the blankets that he has also a chest tube. You are now putting yourself in my shoes. And let's say you're consulted by the ICU team for these acute fractures and post-op pain with splinting. So at this point, what further information would be helpful? And I'm going to open up to the floor. Let's see. Unfortunately, the polling is not working through Zoom, so I will just ask you to unmute yourselves. I'm very curious what your thoughts are at this point in the case.
I think I would want to know what the cause of trauma this patient would have. What kind of trauma?
What kind of trauma? Okay. What other questions might you ask if you're thinking about specific types of blocks, if this patient is even a block candidate?
Yes, and also maybe the coagulation profile, bleeding status of the patient.
Thank you. Yes. Okay, perfect. Someone's also put in the chat, I see ample history. And I think this is referring to like allergies, medications, past medical history. Yeah. So can we get any further information about this patient? Are they on anticoagulation? We're assuming, what are their current labs too, since they've just had a lot of products that they've received that may have changed something. Are there any hepatic issues we should be aware of that could change absorption or the toxic levels if we are going to give this patient a local anesthetic? Okay, so one, I think it's helpful to clarify what is the mechanism of injury. Clarify in your mind, again, what's that location and the type of injury. Perfect. Someone already said coagulation status. What is their current pain regimen? Now, this patient just came out of the OR, so you know what they received in the operating room, but have we started things like, is it appropriate to start, things like paracetamol, Tylenol, are NSAIDs? Have they received opioids? Have they been responsive to that pain regimen so far? Because if they are, great, but this patient, based on the exam, we know he's not. In fact, he's actually splinting from his rib fractures. Number 5, is there any disability or neurologic deficits? And so again, what was their baseline? Did they have this disability beforehand? And is there a new disability that we need to take into account? So is there some kind of impairment and we need to preserve that function as much as possible? Is it tenuous? What upcoming surgeries do we anticipate? So if this patient was extubated, but then in 5 hours they're going back to the operating room and they're going to be intubated and sedated again, that changes the time course of their recovery, right? And of the interventions that I can and I should provide to this patient. And then is the patient consentable? All right, so this patient's had a big day. They're probably not 100%, right? And so if we have these discussions about risk and benefit, How are we setting expectations? Are we doing it with the patient directly and or with their family at bedside? Okay, so the answers. Mechanism of injury. So motor vehicle collision, let's say it was about 60 kilometers per hour. The location and type of injury. So he has a right hemopneumothorax and right lateral rib fractures 5 through 8. His post-operative labs are normal, including CBC, coagulation studies, and TEG. And during ICU, will this patient be anticoagulated per DVT prophylaxis? I'm actually curious, is this something that you commonly do, or does it depend on the situation? What would you do in this case in your practice? And you can put it in the chat too, and I'll watch. Okay, so the current pain regimen, let's say the multimodals are Tylenol, NSAIDs, parenteral opioids, and he's not yet taking PO. And there is, let's say, no other distracting injury, so that's important to know. So there isn't like also a concurrent wrist fracture. And is the skin, is there integrity of the skin? Is there any infection that's obvious? Because I would not put a needle, I would not do a procedure through an area where the skin is not intact. All right. And then my last answers are, what upcoming surgeries do you anticipate? Will the patient have to be intubated again? If they're staying intubated again, then their whole sedation regimen is different. If I place a catheter in an extremity, or let's say in the chest wall or in their back, and a surgeon has to go back and do something in that area, that catheter might actually be in their way. It may become an infection risk. And then lastly, who is the point of contact? Okay, so question for the audience. What types of regional anesthesia should we consider for this case?
I think I would consider the continuous thoracic paravertebral anesthesia, analgesia, and also thoracic epidural with local anesthetics, and also opioid maybe as an additive.
Okay, good. So yeah, so a thoracic epidural is certainly an option, I think, for the case as it's currently presented. And then you kind of gone right to the answer I'm going to eventually get to, which is the continuous paravertebrals. And I would discuss also why continuous intercostal and interpleural analgesia. So why those are not the correct answers. Actually, intercostal analgesia just looks at the nerves right below the specific ribs. And so if you're going to target each nerve under each rib, it's very laborious. And if you know that you have a whole bunch of ribs that are injured, then why not just do one technique that will cover all of those ribs rather than individually? Okay, so that is why I would not choose D. Intrapleural analgesia has not been found to be as effective for rib fractures because it tends to settle. So interpleural is right between our lung pleura and the parietal pleura, whereas, and so the local is put there, but then it tends to become dependent. So it hasn't been as effective. Whereas the paravertebral, right, the local is outside of the pleura. It is next to or para the vertebra. And then your neuraxial options, right, with local anesthetic or with opioid. All right, surprise. They do a CT scan of the head, and during all of this trauma, the patient has a head bleed. Okay, so with that new information, I would probably not do any of the epidurals or any of the direct neuraxial techniques. When we place an epidural, okay, there is always the risk that the needle can go through those layers of the back and enter the dura itself, meaning that we are going into the space with the CSF. And so if there is a CSF leak, that will decrease the transmural pressure, and that increases the risk of another rebleed inside the head. So very important to understand if there's any distracting injury for your trauma patient who presents, Do they have any intracranial concerns, such as a head bleed? If you haven't had time to get a CT or there's a change in the neurologic status, I would get on that right away before you start thinking about fancy nerve blocks. All right, so this is a lovely schematic of chest wall blocks. And again, I'm going to just go over the anatomy very briefly. But in pink, I showed the pecs or pectoral blocks. And then the green is showing a like sternal block. I wanted to focus what's on the red, and that is yellow. So a serratus block. Serratus is a muscle over the anterior chest. Hence, it's the name of the block is derived from that. The intercostal blocks, or ICNBs, are those strips of purple. And so they're aligning, you can see exactly with each dermatome. Very targeted, very specific, but for multiple rib fractures, very limited. In light purple, I'm showing you the distribution for the ESP, or erector spinae block. The erector spinae block is for the erector spinae muscle on the back, running just lateral and superficial to the paravertebra. And you can see it does have some utility, right? It's covering about 4 dermatomes, whereas the paravertebral has much broader coverage and I think greater potential. And there are some studies to say that it is more efficacious. So that is the turquoise. And you can see it's one of my favorite blocks and what my go-to for rib fracture patients. So briefly, the paravertebral block, as I mentioned, it's the local is placed right where basically that black arrow, I'm sorry, the is where on the left I'm showing a black triangle. So this black triangle on the left, we see the rami coming out of the spinal cord. And so a paravertebral block puts local very close to the dorsal and anterior rami, and so it's a very dense, a very powerful block. You'll notice just superficial is that yellow blob, that's our sympathetic chain, and it is yet a secondary reason why paravertebral blocks can, I think, reduce that sympathetic reaction to pain, but also can be associated with some hypotension. It's not as profound as a neuraxial block because it would only get one side. If you're doing a unilateral paravertebral block, but it is in close proximity. And then in the blue square and in the red square, I'm just pointing out some anatomy. I hear a voice. Okay, I'm gonna skip that. So this is just a schema showing the spread of local and why the paravertebral is able to anesthetize multiple dermatomes. It has broader coverage than just single dermatome intercostal block. Why else does the paravertebral block work so well? Because those nerves have just exited the spinal cord, they do not yet have a full layer of perineurium and epivesicular epineurium, and so there's less barrier for the local anesthetic to go through. There are 2 different approaches to placing these blocks. Again, I don't expect you to know those, but I just included these slides, and they can be done by landmark. That was how we did ours, I would say a couple of years ago. But with the advent of ultrasound, and if you have one available and you're interested in these techniques, I would always just advise to go ahead and to use it. These are some images, and you can see on the upper right, I'm showing that the probe can be either transverse or it can be or it can be sagittal. And then in all of the images, you see there's a label for the pleura. So when we're doing this block, we are very close to the parietal and to the lung pleura, and it's something we always keep in mind, that the patient understands the procedure, that they need to stay still, or we're at risk of giving the patient a pneumothorax and puncturing the lung. And so when I approach these patients and I offer them a paravertebral, I always in the back of my mind, I'm trying to assess, are they going to stay still for me? If they're not, they need to understand that there's a very real risk I will have to abort the procedure so I do not cause any harm. I'm very cognizant of time. I realize it's already 9:57, so I'll stop there. What questions do you have so far, either about these specific techniques or about multimodals?